Hello, everyone. I'm Lianne Gensler, rheumatologist at UCSF, and excited to be here to speak about the future therapy of axial spondyloarthritis. I'm sorry I'm not there in person, but I will be around today to answer questions. These are my disclosures, and I will be talking about off-label therapy. So we'll use a case-based approach to address some new considerations with NSAIDs, newer mechanisms with phase 3 and phase 2 results, and then therapies and therapeutic approaches for the future of the treatment of axial spondyloarthritis. I'll start with a case. This is a 33-year-old woman who presented to me with neck pain and a rash. She had been well until 2 years earlier when she developed neck pain and morning stiffness. Exercise and nonsteroidals would help, but not completely, and she had no peripheral joint pain or swelling. And her rash is shown here, and it was diagnosed as palmopustula psoriasis. She had no other extra musculoskeletal manifestations, including no inflammatory bowel disease or uveitis. She had a history of cervical dysplasia. She was an active smoker, noted to be HLA-B27 negative, with high inflammatory markers by serologic testing. And here are imaging studies which show very nicely that she has fused sacroiliac joints, and then a neck x-ray, which shows both syndesmophytes that are bridging and fused facet joints and facet arthritis. So very classic radiographic axial spondyloarthritis with psoriasis. I like collecting disease activity. I find it a nice quantitative way to assess a patient's burden of disease and then following this over time with treatment. You can see that she has very high disease activity here subjectively by the BASDAI, very high functional impairment. And then this is our best measure of disease activity, taking into account the CRP. And you can see she has very high disease activity. These are not new. These are the 2019 guidelines, but I just want to bring into the talk the base of like first-line therapy is nonsteroidal anti-inflammatories and physical therapy, which is strongly recommended. Also a conditional recommendation for back exercises and measuring that disease activity, and against using a treat-to-target approach. At the time that these guidelines were developed, there was no evidence that treat-to-target was relevant for axial spondyloarthritis. I will say we are just getting started on our revision of the guidelines, so we will see what we come up with in the coming year or two. The ASIS-EULAR guidelines were published more recently, so last year, and I want to bring up the point here that they want you to consider, and I think it is really important to consider a patient's comorbidities and the extramusculoskeletal manifestations, because they might determine that you choose a different treatment for your patient. They also recommend a treating to a target, so that's different than the ACR guidelines, and that's based on the TICOSPA trial, which was presented and published in the last couple of years. This trial was a negative trial. It did not meet its primary endpoint. Some key secondary endpoints were met, and there is still controversy about whether we should be treating to target. NSAIDs are still first line, and they do recommend smoking cessation, which is associated with worse outcomes, which I agree with, and this patient was doing. So this is the new evidence that I don't even think is in the literature yet, but I think it's coming. And that's thinking about how we can be more personalized for our patients when we are prescribing pharmacologic therapy that might be metabolized differently according to specific genetic polymorphisms. This is actually the panel at UCSF that I have access to. All of the VA systems have similar access to pharmacogenomic testing, and I think this is going to be in mainstream soon. So why this is relevant for our axial spondyloarthritis patients is you can see that several of the NSAIDs we prescribe are metabolized by CYP2C9. And you can imagine that if you are a poor metabolizer or an intermediate metabolizer of this drug, you might have more side effects because you're not going to metabolize the drug. Similarly, if you're a rapid metabolizer, you might not have efficacy. And so if you went from one NSAID to another and you stayed within this group of NSAIDs and you were a metabolizer, you had sort of metabolizer status of CYP2C9 that would affect this, then you might want to think about switching outside of these several NSAIDs when you are switching because of whether it be side effects or efficacy. So I do find this very important because for me, I use a lot of meloxicam and celecoxib, and they're actually both metabolized this way. So you might say, well, why do I care? Why can't I just empirically try it? And you certainly can. However, there are actually guidelines about what to do depending on metabolizer status. So these are the guidelines on what to do. And this is just as an example for meloxicam, but you can see that if you are an intermediate metabolizer or a poor metabolizer, then you actually should not be initiating the full dose of meloxicam to start. And if you're a poor metabolizer, you should be choosing an alternative NSAID, not aspirin, but an alternative NSAID to that group of 5 NSAIDs that are metabolized by CYP2C9, as an example. What else do we want to share about NSAIDs? So this is the CONSOL study. It was a study looking to see whether if we added NSAIDs, and in particular celecoxib, to a TNF inhibitor, would we be able to have less radiographic progression in patients with radiographic axial spondyloarthritis? And so this study randomized patients to golimumab alone versus golimumab plus celecoxib, and then followed these patients over time. And what you can see here is that the mean change in the MSAS score, which is our numeric scoring method for spinal damage, was not significantly different between the two groups, but you can see numerically those patients on both agents had less radiographic progression, similarly less number of new syndesmophytes, and this is the cumulative probability plot, which again, not significantly different, but numerically you can see less radiographic progression in the combined group. So what we have is that there's not statistical evidence to combine these two agents. There may be a group of patients where it may be most beneficial, those highest risk patients for progression. Perhaps if you really enrich the study for that group, you would see a difference. The limitations on the study was that it was not powered to address this question. This is the ASIS-EULAR guidelines, and so this is new. We used to sort of think about TNF inhibitors as second line after NSAIDs in patients that needed to escalate, and what you see here is that IL-17 inhibitors and TNF inhibitors are put on a lateral playing field as the agent you would go to next after NSAIDs have failed or you are intolerant to. And then also taking into account the extramusculoskeletal manifestations. We've known for a long time that if you have inflammatory bowel disease or frequently recurrent uveitis, you would want to pick a monoclonal antibody-based TNF inhibitor. Here we know that psoriasis, IL-17 inhibitors are better for psoriasis than TNF inhibitors, and so with a significant burden of psoriasis, you might consider an IL-17 inhibitor. So in the presence of pustular psoriasis warranting systemic therapy and radiographic axial spondyloarthritis, an IL-17 inhibitor was started. Showed dramatic improvement in the symptoms and resolution of the psoriasis and serologic inflammation. And I just want to highlight the secukinumab data. This is not new in radiographic and non-radiographic axial spondyloarthritis with response compared to placebo, primary endpoint at 16 weeks. A third of these patients could have been TNF inadequate responder or exposed. And some new evidence for secukinumab in particular. This is actually from RheumNow. Very recently, IV secukinumab was approved for axial spondyloarthritis and psoriasis, psoriatic arthritis. And so that is actually quite helpful for us in the United States because for Medicare patients, this becomes a much more affordable option than the sub-Q formulations of the biologics. And I think it's also helpful to think about the phase 2 data in acute anterior uveitis, where we actually saw efficacy in a phase 2 trial with IV secukinumab for uveitis, which we know that the sub-Q formulations don't treat uveitis. So you might consider using this in a patient that also has uveitis. We have no head-to-head data compared to TNF inhibitors, but this is reassuring and encouraging for a certain population of patients. And then just also highlighting that secukinumab is now approved for hidradenitis suppurativa with efficacy there. And so an expanding indication for IL-17 inhibitors. And certainly several of our patients with axial spondyloarthritis will also have HS, either alone or in association with inflammatory bowel disease. And we'd not be using this in the setting of IBD though. Looking at ixekizumab, so this was done in TNF naive and TNF experienced patients with radiographic axial spondyloarthritis. That's why you see a little bit of a lower response in the experienced group. But of course, we have efficacy for ixekizumab too, and for fair balance, I'm showing all of the data. And then in non-radiographic axial spondyloarthritis, remember this was a 52-week trial. And so you can see both at 16 weeks for the EU and then 52 weeks for the US response to treatment compared to placebo. So I showed you that because I wanted to bring in new data, and that's the bimekizumab data, which was first published in comparison to secukinumab for plaque psoriasis, and this was the New England Journal of Medicine study, which showed that patients on bimekizumab compared to 300 milligrams of sub-Q secukinumab had a better response for complete clearance of skin. They also had more oral candidiasis when you inhibit IL-17A and IL-17F instead of IL-17A alone. So let's look at the data in axial spondyloarthritis. This is, of course, not yet approved in axial spondyloarthritis. It is approved in psoriasis. So this is the data using an ASIS 40 or 40% response. Prior TNF inhibitor was allowed in both studies. It was a small proportion of patients. And on the left, you see the non-radiographic axial spondyloarthritis study. And on the right, the radiographic axial spondyloarthritis study. And I think what's very exciting here is that actually, regardless of whether it's radiographic or non-radiographic disease, you see that the same response is had in both populations with the same placebo response. So very similar results across two trials in two populations of axial spondyloarthritis patients using a 40% improvement compared to placebo. This is looking at the ASDAS groups. So what I want to show you here is that, of course, at baseline, both the placebo and the bimekizumab groups have very high disease activity. And at 16 weeks, what you see is that 46% of patients, and then in the radiographic population, 45% of patients are in low disease activity or less. So that is quite remarkable that we have such a low disease activity by only 16 weeks, and very encouraging as a therapeutic option for our patients with axial spondyloarthritis. Of course, we have no head-to-head data compared to IL-17A inhibitors for primary efficacy here. And then just looking at bone marrow edema, and what you can see in the non-radiographic population, looking at the sacroiliac joints, is that there's more bone marrow edema reduction in the bimekizumab group compared to the placebo group, and similarly more bone marrow edema in the radiographic population in the bimekizumab group compared to the placebo group. So back to our case, and just remembering that she had this amazing improvement on IL-17A inhibitor with resolution of symptoms and signs. 14 months later, she presented with diarrhea, and she was unfortunately diagnosed with Crohn's ileitis, and this is actually from her endoscopy. And so at that point, we stopped the IL-17A inhibitor, and we started a TNF inhibitor. And unfortunately, she very quickly developed pustular and plaque psoriasis that flared and was very disabling to her. This is actually from a telehealth visit where you can see the skin coming off the palms of her hands. So we then moved to a JAK inhibitor. And so I've now taken you through 3 classes of mechanisms. And I think it's helpful to look at this graph and think about who she is. She's axial spondyloarthritis. She also has psoriasis and now Crohn's disease. And so what are the treatment options that will work for her, and why did we choose a JAK inhibitor? Well, it's really 2 classes, and that's the monoclonal antibody-based TNF inhibitors. She refused to go back onto a TNF inhibitor after developing the psoriasis, and then JAK inhibitors. She has been in remission actually on a JAK inhibitor now for several years. So that is certainly an option, especially when these other options fail in the presence of multiple manifestations. I've also used off-label combination of biologics in patients with inflammatory bowel disease and axial spondyloarthritis by combining agents that we think have perhaps better safety. And I'm happy to talk about that more in the Q&A. So this is just looking at the JAK inhibitor data, and there's 4 trials now. Tofacitinib used an ASIS 20 or 20% improvement compared to placebo and has an indication in radiographic axial spondyloarthritis. And then you see upadacitinib both in radiographic axial spondyloarthritis and then DMARD, inadequate responder, and then non-radiographic axial spondyloarthritis, all with efficacy compared to placebo. This is using an ASIS-40 or 40% improvement. And so very good data here to suggest that upadacitinib is a nice option for patients across the spectrum. And this is just showing you the bone marrow edema differences. And what I like about these studies, so this is both upadacitinib, this is non-radiographic axial spondyloarthritis on the left, and then radiographic axial spondyloarthritis on the right. And what you see here on the left is the sacroiliac joint, and on the right is the spine. And in non-radiographic disease, you see the bigger change in the sacroiliac joints, and that's because they're non-radiographic, which means they have less damage and they have more burden of inflammation still in the sacroiliac joints. If you look at the radiographic population, the sacroiliac joints bone marrow edema decreases, but you see more reduction actually in the SPARC spine score. And that's similarly because once you have radiographic disease, your burden of inflammation can shift to the spine. Taking into account comorbidities and re-evaluating the diagnosis in patients that don't respond is an important new recommendation from ASIS-ULAR. These are just some recent studies that have looked at this relationship and shown that in patients with high BMI, there is actually a causal association with disease activity over time. In addition, the more comorbidities you have, the less likely you are to respond to treatment. And similarly, certain comorbidities, in particular depression, really drives both disease activity and functional impairment in a very significant way. So think about screening your patients for these comorbidities or reevaluating the diagnosis in patients that don't respond to treatment. And so here you see, just to make the point really about what to do in a patient with sustained remission, the ASIS-ULAR guidelines recommend considering tapering of the biologic DMARD. We did not recommend that in the ACR guidelines for a variety of reasons, but I want to show you some tapering data. First of all, this is the EMBARK study where patients with non-radiographic axial spondyloarthritis were given etanercept and then in remission were randomized to stop or continue. And what you can see here is that 25% of these patients remained flare-free at 40 weeks of follow-up. And one of the predictors of remaining flare-free was actually if you had no bone marrow edema on the MRI prior to stopping the etanercept. So I think if you're going to have this discussion with patients, generally these patients are going to flare at some point in follow-up, but having no bone marrow edema on the MRI prior to coming off of it can be helpful. This is the ixekizumab withdrawal trial, which took all of the COAST trials and then randomized patients to stay on their ixekizumab versus come off. And you can see that between weeks 24 and 104, 53% of patients flared, so the majority of patients. However, what was helpful to see is that when you rescued these patients that flared, actually 96% of them recaptured at least low disease activity. And so that's the good news, is that if you do this experiment with a patient, then there is a good chance that you're going to get them back if you try to recapture them if they flare. I'd like to talk about radiographic progression now in axial spondyloarthritis with some new data. To start, we know that very few people actually progress over at least a 2-year period. On the left, you see the MEASURE trial, MEASURE 1 with secukinumab, and on the right, you see the original phase 3 adalimumab trial compared to an OASIS observational cohort with no significant radiographic differences in those patients at 2 years. However, we have observational data that's emerged that suggests that biologics, especially when used longer, more than 2 years, are associated with less radiographic progression. And so the SURPASS trial was a trial designed to test in a head-to-head way. This is the first head-to-head trial of biologics in radiographic axial spondyloarthritis, secukinumab at 2 different doses versus an adalimumab biosimilar for a superiority design of radiographic progression. And the superiority was designed for secukinumab. This was a Novartis-funded study. And so these were patients enriched to progress. They were patients that had radiographic disease, high disease activity, and they either had to have a high C-reactive protein or they had to have at least one syndesmophyte on spinal x-rays. And you can see that the baseline characteristics of these patients had an average CRP of 20 milligrams per liter and 7 centesima fights at baseline. And so this was the design of the study. They were then followed for 2 years and then re-evaluated for imaging studies. These patients were dose-blinded to secukinumab, but not blinded to whether they were on secukinumab versus adalimumab. And so this is the results, and you can see the cumulative probability plot on the right, where you see very much overlapping lines of the adalimumab in red compared to the secukinumab arms in blue, suggesting actually that there is no difference in radiographic progression benefits between these two arms. And you can see that on the left, the proportion of patients with 0 radiographic progression was around 66%, no matter which arm you were in. And so the kappa here is, despite the fact that the trial did not meet its primary endpoint, is that the majority of these patients who were enriched to progress did not progress over time. And that is very encouraging, at least, to help us generate supporting evidence for the fact that when you suppress inflammation long-term in these patients that would be progressing at baseline without treatment, they are not progressing. I want to highlight the fact that IL-23 inhibitors are not effective. We know this. Phase 3 trial in ustekinumab was shut down, and then risankizumab phase 2 trial in axial spondyloarthritis also did not meet a primary endpoint, and so we have not developed IL-23 inhibitors in axial spondyloarthritis further. I think the question remains as to whether in the setting of axial psoriatic arthritis, IL-23 inhibition would be helpful. And so this is the STAR trial, this is just showing you the study design of patients with axial psoriatic arthritis who are being randomized to guselkumab versus placebo, and then will be followed up with imaging to look at both efficacy and imaging findings. And so this will be very helpful for us to determine whether patients with axial psoriatic arthritis are truly a different endotype compared to patients with axial spondyloarthritis who do not respond to IL-23 inhibition. I want to switch to thinking about what our future is in axial spondyloarthritis and start with a very difficult to manage patient. This is a 37-year-old patient of mine with juvenile spondyloarthritis who started to have symptoms at 12, both axial and peripheral disease. And you can see he's had multiple hip replacements and knee replacements. He started his first biologic DMARD at 22 with variable response to a TNF inhibitor, no history of any extra musculoskeletal manifestations. He has poorly controlled hypertension, osteoporosis, and chronic kidney disease from analgesic nephropathy. And his medications when I first saw him included indomethacin and infliximab every 4 weeks, prednisone of 20 milligrams, opioids. And at the time I saw him, I thought, well, this is easy. I can just put him an IL-17 inhibitor. He hasn't tried that, and hopefully he'll do better. And actually, you can see that he did actually initially improve, and we were able to taper his prednisone to 10 milligrams. However, you can see over time, he has never really had a CRP that is normal, and this is in 2023. He still has very high disease activity. His CRP is not normal. His SED rate is still elevated. He, for his osteoporosis, had teriparatide added. And then with new neck pain, I did some imaging and, of course, found atlantoaxial instability, basilar invagination with pannus and erosion. So this is a patient that we would call difficult to manage or difficult to treat in the rheumatoid arthritis literature. It's an evolving concept, but the question is what to do with these patients who, no matter what you've done for them, continue to have high disease activity. And so this is not an axial spondyloarthritis, it's actually an ulcerative colitis, but it shows that actually when you combine a TNF inhibitor and an IL-23 inhibitor, you get better endoscopic remission and ulcerative colitis disease activity control compared to either of the biologic monotherapies alone. So I think this is an exciting future for us to consider combining biologics in axial spondyloarthritis. I don't think we have evidence that IL-23 inhibition on top of anything will make a huge difference, though we can do that, especially in the setting of IBD or perhaps psoriasis. But I do think that we are moving to a future of not thinking about monotherapy alone. I want to bring up sonelokimab. So this is not just an IL-17A inhibitor, but an AF inhibitor. But unlike bimekizumab, which is a monoclonal antibody, this is a nanobody, and so it's a very small molecule. And so this is exciting. This is evidence from psoriasis showing efficacy. Nasopharyngitis was the most common treatment emergent adverse event. They also had a little bit of oral candidiasis, similar to other IL-17 inhibitors. The novelty here is not just that this isn't a monoclonal antibody, but because of its small size, theoretically, this could target tissue and have penetration that might be different than bigger molecules. And I think that is a little bit theoretical, but I think it has exciting potential. And then izokibep is a small molecule, so it's not an antibody, but it does block IL-17A. And this is the phase 2 data from psoriatic arthritis. We have no data in axial spondyloarthritis, but I think still exciting to think about because we know that IL-17A inhibition does work, and sometimes the reasons that the monoclonal antibodies stop working are because of immunogenicity, and so perhaps small proteins will have less of that. Similar types of treatment of emergent adverse events, no serious adverse events or new onset IBD. Keep in mind, this is psoriatic arthritis though. And so exciting to think about another mechanism of action that might be helpful in patients with axial spondyloarthritis. I want to bring up TYK2 inhibitors. So deucravacitinib, of course, which this is also in psoriatic arthritis. It's approved in psoriasis. So TYK2 is interesting in that it's part of the JAK family, but it's really JAK4. And so unlike the rest of the JAK inhibitors, this does not have the same side effect profile. And so the phase 2 data in psoriatic arthritis showed efficacy versus placebo at week 16, and phase 3 is ongoing. I think what's also interesting to think about is from a safety standpoint, we know that patients who actually have a deactivating genetic variant of TYK2, so TYK2 doesn't work, are protected from some immune-mediated diseases, but they do not have an increased risk of hospitalization for infections that we might think about with other JAK inhibitors. So again, exciting to think about a potential mechanism. We have no data in axial spondyloarthritis. I want to end with, can we cure axial spondyloarthritis by getting rid of the pathogenic T cell that maybe exists? And so this is just a single case report out of Russia where they, of course, we know in the last couple of years that there's this specific CD8 positive T cell that's been identified. And so this group took a patient with radiographic axial spondyloarthritis and depleted this specific T cell with an antibody. And then after a few years was able to get the patient not just into clinical remission, but also stop the TNF inhibitor that the patient had been on, and the patient has apparently remained in remission. A single case report over the follow-up 4 years on just this treatment and no other biologic treatment. So I think it's exciting to think about that this is a single patient, but can we be thinking about this? This is, of course, specific to patients that are HLA-B27 positive. So in summary, consider NSAID choices or pharmacogenomic screening in patients at risk for NSAID adverse events. And in particular, there are certain NSAIDs that fall under the same CYP metabolism pathway. There is no clear radiographic benefit to add an NSAID to a TNF inhibitor at this time, although I think there is a population of patients at high risk that might benefit, and in particular from celecoxib. Not all therapies work for all domains, with some paradoxical effects versus are these patients just primed to develop those manifestations? And when you're out of tools, think outside the box. Off-label use, combination therapy, there might be a role for titration, which I think we probably all do to a certain extent. And then once in remission, and what I call remission is at least a year of remission, then it becomes a shared decision on how or whether to taper patients. Head-to-head data for radiographic progression suggests similar effect of secukinumab versus an adalimumab biosimilar. And then thinking about novel mechanisms of action that we can expect perhaps with better tissue penetration and or safety. Thank you very much for your attention. I'm happy to take any questions.